Welcome to our second episode of Antibiotic Answers, where we take your antibiotic questions and give short, guideline-based answers while focusing on using antibiotics appropriately and preventing resistance. Please feel free to submit your antibiotic questions to emily.perry@ndsu.edu. This episode is about community-acquired pneumonia. Our first question is, what antibiotics should be used empirically to treat community-acquired pneumonia in the outpatient setting? The choices for empiric adult outpatient CAP therapy for healthy adults without comorbidities are amoxicillin, doxycycline, or a macrolide like azithromycin or clarithromycin, but remember to only use macrolides in areas where pneumococcal resistance to macrolides is less than 25%. The choices for empiric adult outpatient community-acquired pneumonia antibiotics in healthy adults with comorbidities like chronic heart, lung, liver, or renal disease, diabetes, mellitus, alcoholism, malignancy, or asplenia are a combination of either amoxicillin clavulanate 500 mg, 125 mg 3 times daily, or amoxicillin clavulanate 875 mg, 125 mg twice daily, or amoxicillin clavulanate 2000 mg 125 mg twice daily, or a cephalosporin like cefpodoxime 200 mg twice daily, or cefuroxime 500 mg twice daily, in combination with either azithromycin 500 mg on the first day, then 250 mg daily, or clarithromycin 500 mg twice daily, or for the extended release 1000 mg once daily, or doxycycline 100 mg twice daily, or monotherapy with a respiratory fluoroquinolone like levofloxacin 750 mg daily or moxifloxacin 400 mg daily. The choices for empiric pediatric outpatient CAP antibiotic therapy for children less than 5 years old are amoxicillin or alternatively amoxicillin clavulanate. And for children greater than or equal to 5 years old, the choices are amoxicillin or alternatively amoxicillin clavulanate with a max dose of 4,000 milligrams per day. But for children greater than 5 with presumed bacterial CAP who do not have clinical, laboratory, or radiographic evidence that distinguishes bacterial CAP from atypical CAP, a macrolide can be added to beta-lactam therapy for empiric therapy. Our next question is, what antibiotics should be used empirically to treat community-acquired pneumonia in adults in the inpatient setting without risk factors for Pseudomonas aeruginosa or methicillin-resistant Staphylococcus aureus? The choices for empiric inpatient community-acquired pneumonia antibiotic empiric therapy without MRSA or Pseudomonas aeruginosa risk are combination therapy with a beta-lactam like ampicillin sulbactam, cefotaxime, ceftriaxone, or ceftaroline, and a macrolide like azithromycin or clarithromycin, or monotherapy with a respiratory fluoroquinolone like levofloxacin or moxifloxacin. Remember, these dosages are based on normal renal function. Our next question is, what antibiotics should be used empirically to treat community-acquired pneumonia in the inpatient setting with risk factors for Pseudomonas aeruginosa or MRSA? The choices for adult inpatient community-acquired pneumonia antibiotic selection for patients with MRSA or Pseudomonas aeruginosa risk are vancomycin and linezolid for MRSA, and for Pseudomonas, piperacillin tazobactam, cefepime, ceftazidime, meropenem, and imipenem. Our next question is, what antibiotics should be used to treat inpatient pediatric patients with community-acquired pneumonia? Pediatric inpatient community-acquired pneumonia patients that are fully immunized with conjugate vaccines for Haemophilus influenzae type B and Streptococcus pneumoniae, when local penicillin resistance in invasive strains of pneumococcus is minimal, can be treated with ampicillin or penicillin G, or alternatively ceftriaxone or cefotaxime in addition to vancomycin or clindamycin for suspected MRSA. Patients that are not fully immunized for H. influenzae type B and S. pneumoniae and local penicillin resistance in invasive strains of pneumococcus is significant can be treated with ceftriaxone or cefotaxime in addition to vancomycin or clindamycin for suspected MRSA. Alternatively, they can be treated with levofloxacin with an addition of vancomycin or clindamycin for suspected community-acquired MRSA. Our next question is, should patients with suspected aspiration pneumonia receive anaerobic coverage in addition to standard empiric treatment? Anaerobic coverage should only be used once in a blue moon. You should only cover for anaerobes when a lung abscess or empyema is suspected in the patient, and this happens very infrequently. Our next question is, how long should community-acquired pneumonia be treated for? The discontinuation of treatment should be based on resolution of vital sign abnormalities, and the duration should be at least 5 days. Thank you for listening. If you have a question you'd like answered, please email it to emily.perry@ndsu.edu.